All right. Hello, everyone. Welcome to our webinar, Reproductive Violence in Gaza, New Research Findings and Calls to Action. Thank you very much for joining us today. My name is Lindsay Green, and I'm the Deputy Director of Research at Physicians for Human Rights. Our moderator, Sam Zarifi, who's the Executive Director of PHR, will be joining us shortly. He was delayed in another briefing. But to ensure that we can get to our important discussion, I'll kick us off and pass off to Sam when he's able to join. In October 2025, a fragile ceasefire was declared in Gaza, but for Palestinian women, particularly those who are pregnant and lactating and their infants, the crisis persists. Repeated civilian displacement, destruction of infrastructure, the collapse of Gaza's health system, and ongoing Israeli restrictions on the entry of aid and aid groups, including food, essential medicine, and reconstruction materials, continue to endanger pregnancy, childbirth, and reproductive health. In today's webinar, we will share the findings of two independent reports published by Physicians for Human Rights Israel and Physicians for Human Rights with the Global Human Rights Clinic at the University of Chicago Law School on how the collapse of Gaza's health system, restrictions on humanitarian aid, including medical supplies and food, and persistent displacement have caused severe harm to maternal and newborn health. We will examine the consequences of these actions for reproductive autonomy and how they constitute reproductive violence. And we will also discuss the current situation in Gaza and outline key recommendations for action to provide urgent medical care and nutrition to women of reproductive age and infants in Gaza. As a quick housekeeping note, please submit all questions through the Q&A function of the webinar, which you can find at a button at the bottom of your screen. The webinar will also be recorded, and links to the reports and resources mentioned during the webinar will also be circulated. We're joined today by three wonderful panelists who I'll introduce very quickly. The first is Lama Bakri. Lama is a psychologist currently working as a project coordinator at Physicians for Human Rights Israel's Occupied Palestinian Territories Department. Over the past 2 years, her work has focused on forcible transfer affecting Palestinian communities in the West Bank and reproductive violence in the Gaza Strip. Our next panelist is Payal Shah. Payal is an international lawyer with 2 decades of expertise working on gender, health, and human rights. She is the Research, Legal, and Advocacy Director at Physicians for Human Rights, where she oversees PHR's efforts to reform and achieve accountability for violations of international human rights, international humanitarian law, and international criminal law. Payal has worked on documentation, litigation, and advocacy on conflict-related gender-based violence globally, including in the Democratic Republic of the Congo, Ethiopia, Nepal, and Ukraine. And finally, Dr. Nahreen Ahmed. Dr. Ahmed is a second-generation Bangladeshi American pulmonary and critical care physician. She is a humanitarian aid worker and global health leader in the area of emergency response, health innovation, and capacity building in crisis and conflict zones. She has worked to implement innovative and sustainable programs that improve access to healthcare and system strengthening with projects such as mobile clinics and capacity building for healthcare workers in Ukraine, Gaza, Sudan, Yemen, and Syria. In her most recent role, she has led field-level emergency response efforts in Gaza with 4 deployments since October 2023, most recently returning in December 2025. She is faculty at the Hospital of the University of Pennsylvania, where she continues to attend patients alongside her other role as a technical consultant with the Gates Foundation, focusing on the improvement of maternal and neonatal health outcomes through innovation in fragile contexts. Thank you all for being with us today. To start, I will pass the mic to Lama.
Hello, everyone, and thank you for joining us today, whether it's morning or evening where you are. So let me start off by presenting the background of this project. Last year, PHRI has published a report in October 2025 that provides a legal and health analysis of the Gaza genocide. We basically argued that Israel has imposed conditions of life on the Gazan people that are meant to bring about the destruction, the physical and psychological destruction of parts of the Gazan people. This report, we started working on this report earlier that year, and simultaneously, we also started contacting some of our colleagues in the Gaza Strip. I was in contact with a nurse who was displaced to Miskin Layan refugee camp. It's a camp in Mawasi Khan Yunis. Uh, Lubaba has basically worked closely with pregnant and lactating mothers before the war. And during the war, she accompanied pregnant and breastfeeding mothers in that specific camp, and she still works there until this day. What we really wanted to focus on in this report was the personal stories of women and the victims of these policies that were imposed by the Israeli authorities. And in this report, we didn't intend to make further analysis, legal analysis of, but rather just to show how these conditions have affected women disproportionately. So as I mentioned, the camp was established in 2024, and it was established in response to the second wave of displacement from Al-Nasser Hospital and UNRWA schools. And it houses today more than 700 families, and it houses mainly women and their children. In our report, we chose to focus on three conditions that we believe to have the most impact on the health and well-being of pregnant and breastfeeding mothers and their babies. The first was the destruction of the healthcare system and the denying of access to care, whether it's through attacking maternity wards, shelling the Basma fertility clinic and other healthcare facilities who provided obstetric services for mothers, whether it's through the killing, injuring, and kidnapping of healthcare provider workers, or the restriction of medical supplies and medical equipments to go into the Gaza Strip. And of course, the collapse of the referral system and the medical evacuations out of Gaza. Uh, this we've delved in it very thoroughly in our genocide report. The second one was the starvation as a weapon of war and how that has disrupted pregnancy, has caused complications during both pregnancy, delivery, and labor, and later on lactation. Coupled with the restriction and the limited access to baby formula that these women were dealing with. The third one that we chose to focus on was displacement. And just to go back to our genocide report, we basically presented four conditions. The first two were the ones that I've mentioned already, and the other two were social determinants of health and environmental determinants of health. Social ones mainly focus on access to education, to other basically social services, and the environmental is access to clean water, proper sanitation, etc. So the third condition that we've presented in our current report is the displacement, as we saw that through the repeated displacement of communities in general in the Gaza Strip, and specifically to pregnant and lactating mothers, access to both social and environmental determinants of health was severely impacted. And so these were the three main conditions that we focused on, and through personal stories and in-depth testimonies, we were able to translate these numbers into the everyday struggles that mothers in Gaza had to deal with in the past 2 years. I'll go over some data probably that it was not collected by us. Obviously, it's data that was published from the both the Ministry of Health, UN, and WHO. So in the first half of 2025, only 17,000 births were recorded, making a significant decrease from 29,000 births reported during the same period in 2022. This represents a decline in almost 41% in the birth rates just in a period of 3 years in the Gaza Strip. In July 2025, 33% of babies, almost 5,500 babies, were born either prematurely, underweight, or required admission to neonatal intensive care. The numbers from the 21 women that I've contacted, and I've also, let me just mention that I've contacted these women in February of 2025. I did follow-up calls with them in July 2025, and I'm still in contact with a good number of them. All 21 women have been displaced up until February of 2025, but minimum 3 times, and the maximum that I spoke with was 6 times. While 14 of them had lost their homes to bombardment, all of them faced severe challenges in providing adequate food and nutrition for their children, with most forced to ration every meal to ensure their babies at least could eat a meal once a day. 13 of them experienced difficulties in breastfeeding, while 14 others have reported birth complications. And 18 of the 21 women have lacked regular access to essential supplements like folic acid. These numbers, although it's limited to one camp, but these numbers speak louder, I think, than like the percentage of participants who have dealt with these complications really shows how severe the situation was for these women, and it still is up until this day. Generally, we know that the situation today is dire. We know that the weather conditions are very bad. In the past 2 months alone, 10,000 tents have been damaged in Gaza, over 10,000. And we know that 10 children have died up until this point from hypothermia. Access to baby formula, to enough healthcare that's meant to basically allow the women to recover and to go back to normal levels of nutrition that to recover also from malnutrition has not been alleviated in any way. The Rafah border is open, but patients are not really, like, we know that there is a list of 18,000 patients who are waiting to be medically evacuated, and around 22% of them are children. Yeah, and this, what, like, the bottom line of our findings and of this report is the compounding effect of all of these conditions that were created to maintain a state of war, to maintain on the bodies and the psyches of women and their babies. This orchestrated reality has a domino effect, compounding harm and making it harder for women and their babies to survive and recover. And we don't think that it was incidental. We do think that it was a deliberate policy to create these conditions. So even though the immediate killing of women and their babies have stopped by the ceasefire, the stopping of the bombardment, the slow death of the population is still ongoing. I'm gonna stop here and move to you, Mar.
Thank you so much, Lama. I really appreciated that presentation. And I want to say that research that Physicians for Human Rights has done with the University of Chicago Global Human Rights Clinic really echoes so many of the findings that the PHRI report has uncovered as well. So first, I just would like to say thank you to the audience for joining us today and for my co-panelists. As we've heard since the beginning of the Israeli military operations in Gaza, following Hamas's October 7th attack on Israel, the UN, humanitarian actors, and civil society have documented Israel's attacks on health facilities, including specifically those providing reproductive health care. They've documented restrictions on food and medical supplies, and documented the continued displacement of Palestinians in Gaza. And taken together, these different factors have led to these agencies and actors consistently raising concern about the devastating harm caused by these actions to reproductive health of people in Gaza. The UN Commission of Inquiry report published in September 2025, based on data collected through July 2025, found that Israel's attacks on facilities providing reproductive health care and restrictions on food and medical supplies were intentional and systematic and resulted in devastating harm to reproductive capacity in Gaza. However, we know that since 2025, and specifically in the period from March to May 2025, Israel responded to these findings not by pulling back or introducing new protections, but instead further restricting access to humanitarian aid in Gaza. Israel also continued to target health care through direct attacks and bombardment of health facilities, as well as sweeping restrictions on medical supplies being allowed to enter Gaza. These attacks and restrictions harm reproductive health, and specifically the health and well-being of pregnant, postpartum, and lactating women and their newborns. As Lama noted, right, there's been a 41% decrease in the birth rate in Gaza, documented between May and June 2025, compared to the same time in 2022. And this is a really profound finding. Today, a fragile ceasefire is being tested by ongoing violence, but there have also been inadequate steps towards accountability for reproductive violence or any other violation of international law in Gaza. Women and babies are still facing dire conditions. Notwithstanding some improvements in the past months, Israel's restrictions on medicine and food to Gaza to this day continue to cause a crisis for people throughout the Gaza Strip, significantly affecting pregnant women, new mothers, and babies. So, with the Global Human Rights Clinic at the University of Chicago Law School, PHR sought to examine the impacts of attacks on health and restrictions on food and medical supplies on women of reproductive age, including those trying to conceive, as well as pregnant, postpartum, and lactating women and newborns from January to October 2025. We aim to understand if there have been shifts in tactics of war following different reports from the UN Commission of Inquiry, as well as other stakeholders. And through that analysis, to provide evidence towards the determination of foreseeability and preventability of health harms. Our analysis is based on 78 interviews with health professionals who went to Gaza on short-term medical missions, an analysis of the record of warnings issued concerning risks to reproductive health as a result of the tactics of war used in Gaza, 23 reports of direct attacks on reproductive health facilities in Gaza from January to October 2025, collected by our partner Air Wars, and the established medical literature on the known reproductive health harms resulting from acute malnutrition and denial of proper prenatal and postpartum care. We had multiple findings as a result of this analysis. First, we found that malnutrition and lack of access to care led to infertility, miscarriages, complications, and death. Clinicians interviewed by PHR and GHRC saw the severe impacts of limited access to food and healthcare on women and children in Gaza. They reported seeing how malnutrition and lack of access to healthcare led to infertility, miscarriages, complications, and death, reporting women presenting with menstruation issues, infertility, and anemia due to prolonged malnutrition. A nurse who worked in Gaza in January 2024 shared, "We clinically saw it in women not having periods because they're so severely malnourished. We saw it in women who were having miscarriages, women who weren't lactating, because when you're pregnant or lactating, your caloric intake requirement increases. And these otherwise healthy women with no comorbidities were not producing any breast milk, even though they had in previous pregnancies." A gynecologist who worked in Gaza in February 2024 noted, "Every single woman I've seen, pregnant or not, was malnourished." Similarly, clinicians reported pregnant women developing critical complications during pregnancy, some of which resulted from acute malnutrition directly, and some of which were made more difficult to manage due to acute malnutrition. This resulted in observed increases in miscarriages and preterm births. Women who became pregnant experienced preterm and prolonged labor, but lacked the necessary medical supplies to ensure safe labor and delivery. PHR and GHRC documented that Israel's extreme, inconsistent, and deliberately opaque restrictions on medical supplies coming into Gaza also resulted in significant harm to reproductive services. A broad range of essential items have been denied under what's called the dual use designation or delayed due to unclear policies. Mothers also struggled to feed newborns and infants due to impeded lactation, where breastfeeding was not possible despite clinical supports. Infants also were unable to access age-appropriate therapeutic formulas, so there weren't the therapeutic formulas needed for infants suffering from acute malnutrition. Yet, severe restrictions on bringing baby formula into Gaza further limited clinicians' ability to ensure that babies had the nutrition they need to survive and avoid malnourishment. A healthcare provider who visited Gaza following the complete blockade in May 2025 described the instructions they received from the IDF via WHO, including not to bring in baby formula, to ensure they were able to pass Israeli checkpoints and enter Gaza. They said, "We were specifically told not to bring baby formula with us because it was not allowed. We were specifically told not to bring antibiotics or pain medication with us because it was not allowed by the Israeli soldiers. And if we're caught, we risk being basically denied entry." Compounding this, attacks on reproductive health facilities limited access to care to prevent and treat pregnancy and neonatal complications and health harms. For over 2 years, Israel has repeatedly attacked hospitals providing broad reproductive health services, as well as more specialized units. These attacks destroyed all facilities providing infertility treatment and further limited the availability of specialized services that were already restricted before October 7, 2023. Clinicians highlighted that treating the consequences of malnutrition in pregnancy was made more difficult due to the limited beds in blockaded facilities, damaged hospitals and inoperable facilities, and barriers to accessing medical supplies. An interviewed neonatologist shared the compounding effects of malnutrition, stress, and attacks on health outcomes for premature babies, saying, "I saw a lot of preterm births, babies born anywhere from 28 to 33 weeks. We had a baby that suffered a brain injury from a lack of oxygen during delivery. That baby did not get the treatment that baby needed or standard of care because they didn't have the right equipment to take care of that baby. And also because Al Shifa Hospital, which would have been where the baby would have been transferred to, was destroyed." Between January and October 2025, PHR and GHRC found that health facilities providing reproductive health care were repeatedly attacked, blockaded, and raided. An interviewed healthcare provider who visited Gaza in early 2025 described what Kamal Adwan Hospital looked like after being attacked and raided by Israeli forces. "It was just toxic. There is a poisonous smell in the air, acrid smoke still hanging, everything burned and charred, crunching medication vials under our boots. Kamal Adwan had been one of the only functioning neonatal ICUs in the north at the time. We walked through the neonatal ICU, which hadn't been burnt, but had been destroyed. There were incubators that had been smashed and strewn about. The whole facility was destroyed." Our analysis determined that the suffering and death of pregnant, postpartum, and lactating women and newborns were foreseeable and foreseen. The available evidence indicates that the predicted and predictable consequences of food deprivation, destruction of medical infrastructure, and restrictions on medical supplies in Gaza were deliberately or recklessly disregarded, resulting in an avoidable crisis that harmed women's ability to menstruate, have healthy pregnancies, give birth safely, and breastfeed, and caused infants to die of malnutrition and dehydration. Beyond the immediate impact, future generations may suffer from the physical, mental, and social results. PHR and GHRC have found that the tactics of war in Gaza constitute reproductive violence. There are special protections in international humanitarian law for pregnant women and children. Pregnant, postpartum, and lactating women in Gaza who suffered negative reproductive health outcomes because of targeting of health facilities, restrictions on essential medical supplies entering Gaza, and acute malnutrition due to limits on essential humanitarian food aid should be considered victims and survivors of reproductive violence, which is defined as acts or omissions that cause harm by interfering with reproductive autonomy and rights, or violence directed at people because of their actual or perceived reproductive capacity. Reproductive violence is prohibited under provisions of international humanitarian law, international human rights law, and can constitute international crimes, including war crimes, crimes against humanity, or acts of genocide. Attacks on health are generally prohibited in international humanitarian law. In the rare cases that such attacks are permitted, they must still occur in line with principles of precaution and proportionality. The doctrine of proportionality prohibits attacks that would be expected to cause incidental loss of civilian life, injury to civilians, damage to civilian objects, or the combination thereof, which would be excessive in relation to the concrete and direct military advantage anticipated. Such calculations are increasingly understood to require consideration of reverberating impacts of attacks on health, including foreseeable consequences when patients are unable to receive adequate medical care. Determinations of proportionality must consider the gendered impacts of attacks on hospital, aligning with the special protection of pregnant women under international humanitarian law. For example, the International Committee of the Red Cross has stated that the failing to recognize that an attack on, and I quote, the only hospital with gynecology and obstetric services, in addition to other health services, such that the damage to it would spike mortality, particularly among women and children, is a violation of this principle. The doctrine of precaution requires constant care and all feasible precautions to be taken in military operations to minimize incidental loss of civilian life, injury to civilians, and damage to civilian objects. This too requires a gender analysis. For example, an assessment and understanding of whether certain medical services are more accessible or important to women than others. For example, the availability of gynecology and obstetric services, which can help understand not only the potential harm to civilians that could result from a particular attack, but also how to mitigate those risks. So taken together, the attacks on healthcare, in particular reproductive healthcare facilities, as well as the denials of adequate medical and nutrition supplies, also violate these special protections granted to women and children during conflict and occupation, which requires that their specific protection, health, and assistance needs are met. So what now? So what we are looking at is the ceasefire in place, and we are seeing that there are several recommendations that need to be put into action to start addressing the needs of these populations. First, we need to see restoration of access to reproductive health care and adequate water, nutrition, and sanitation. These are really urgent priorities to halt the ongoing harms. Despite the current ceasefire, the harms we've documented will only continue until aid flows are adequate and consistent to Palestinian civilians and the health infrastructure is rebuilt. Gaza has seen improved flow of humanitarian aid, including food and medical supplies, as well as increased food production. However, there are still significant restrictions on humanitarian supplies under the dual-use designation. Healthcare workers also continue to report significant shortages at hospitals in Gaza, which I know we'll hear more about today. These restrictions have been compounded by the recent Israeli government decision to bar 37 international aid groups from working in Gaza, which play a critical role in saving lives and supporting the heroic local medical staff. INGOs also deliver more than half of food assistance in Gaza, support about 60% of field hospitals, implement 3/4 of shelter and non-food item activities, and provide all treatment for children with severe acute malnutrition. So these are really critical potential losses in aid and support. Our ongoing data collection also shows that at an individual level, international doctors are still regularly being impeded from entry to Gaza and facing significant restrictions as to the medical supplies and equipment that they can bring in to be able to do their jobs. Finally, while people in Gaza are struggling to get the healthcare they need due to the total collapse of the health system, there is an urgent need to open humanitarian corridors between Gaza and the West Bank and East Jerusalem, as well as third state evacuations for women and newborns who have needs that cannot be met in Gaza. None of these are being sufficiently prioritized. I'll close by saying that each day that passes without adequate food and access to medical care for pregnant and lactating women and newborns diminishes the reproductive capacity, safety, and autonomy of Palestinians in Gaza. This is really an urgent priority. Maybe I can pass to Dr. Ahmed.
Yeah, thank you. I just kind of want to take a moment to bring us down to the field level on an individual patient basis. My most recent visit to Gaza was during the ceasefire in December, and that was my fourth time there. entering Gaza with the expectation that there would be more aid, given that we were in the ceasefire phase. And unfortunately, the reality is, as it was then when I was there in December, and most recently speaking to colleagues that are currently there, international aid workers, as well as my Palestinian colleagues, the limitation of aid is a ruthless thing to witness during a ceasefire. Um, the excuses about active conflict and escalation of kinetic activity being the reason for a limitation of aid was one thing pre-ceasefire. However, now, as a part of the plan, that was essentially one of the objectives. What you can see, and just to kind of lean on the data, which was also very much confirmed on the ground, less than 200 trucks a day have been entering since the ceasefire, and only 5% of that is health related. And what does that look like? That looks like the absence of antibiotics. That looks like the absence of gauze, something that is so basic. The absence of proper prenatal care, so prenatal medications. Most of the pregnant, I worked in the ICU in the emergency room. Most of the pregnant patients that came in were coming in with problems that were easily treatable at an outpatient center, but they were sicker because they were severely malnourished. Everybody looks anemic, having gone there since January 2024 up until December 2025. I've witnessed my own colleagues losing weight, looking more pale. And just because we're seeing pictures in the media that there's food available, it does not necessarily mean that access to proper nutritious food is actually happening. And so what you're seeing is that, yes, there might be more things on the market. It's incredibly expensive. So malnutrition continues to be an issue, which is, as most people have learned now, is a severely prohibits wound healing, severely prohibits the immune system from working properly. And so again, why are pregnant patients coming in sicker than usual? It's because they're severely malnourished, their immune systems are not working properly. There was a woman that came in with a urinary tract infection that should have been easily treated as an outpatient, and she was severely septic. That means she was in organ failure from something that, again, could have easily been treated. Again, we didn't have access to the right antibiotic in order to treat this properly either. And so infection control is also a problem, again, because of supply limitations. So that means that hygienic practices that normally would prevent, infections and things like that during things, let's say, like C-sections or even during labor and delivery are not happening. So that puts women and babies at risk of infection in a situation that's bad enough, given the degree of malnutrition and the fact that, as the team mentioned, the increase in premature births means that babies are being born without their immune defenses. Already they're vulnerable as a newborn, but even more so premature. Now, as a background, I also am a lung doctor on top of being an ICU doctor, and something I want to mention has not been mentioned is the air quality. We talked a lot about malnutrition, we talk about supplies, but let's talk a little bit about what I witnessed as far as the environmental conditions. So first of all, of course, it's the flooding. It's winter now. It's freezing. Babies are dying of hypothermia, which absolutely should not be happening. And on top of that, you can smell in the air plastics burning. You can smell wood burning, and this is happening in enclosed tents with no ventilation. During the winter season, viral illnesses are rampant. So on top of that, and breathing in poor air, people are coming in with coughs that are not going away, severe pneumonias, and this is really leading to extremely poor health. There's so much precedent as to why this is happening. Many in the US will maybe recall that after 9/11, many frontline workers were being seen, and I worked in New York City as a pulmonologist, and 15 years after 9/11, seeing firemen and policemen who had helped clean up debris having respiratory lung issues that many years later. So why I'm saying that is because there's 65 million tons of debris versus the 2 million tons of debris that we saw in New York City. That means that that's the amount of debris that's causing poor air quality that pregnant women and premature babies whose lungs have not developed properly are breathing in. So the number of caustic effects that we're seeing across pregnancy, across postpartum, both in newborns and in moms, is it's absolutely man-made, and we are seeing the effects firsthand. From colleagues that are there now, we're also seeing the medical evacuation side of things. less than 50 miles away from Gaza is West Bank and East Jerusalem, and easily a humanitarian corridor, if the political will was there, could have been created in order to evacuate people to somewhere closer where they could receive proper care. A colleague of mine has a young patient who has a vaginal cancer that is rare, that has been on the evacuation list for 6 months. She shared with me today that the concern is that this young girl may not survive long enough to actually be evacuated and receive the care that she deserves and that she needs. This means that this girl can die or potentially get to the point where the cancer that she has is no longer curable. And then again, preventing her from actually having a chance at reproductive success in the future. So overall, and then of course, just to kind of lastly mention, the blocking of aid groups and the blockade of international aid workers. I myself witnessed entering into Gaza in December. It was actually the end of November at that time. There were multiple aid workers on my actual convoy that were sent back. That means that they were approved the night before we entered, which already that process is complicated, and many aid workers are not approved, that you fly all the way to Jordan and then are actually told that you're denied entry on the night before you're supposed to leave for Gaza. This means that highly specialized physicians and nurses who are required to provide care that is unavailable because of healthcare workers being imprisoned or killed in the process of the last 2 years of genocide are not able to enter. On top of that, those that were able to enter were actually turned away, 3 people to be exact, on the convoy that I was on. Things that were sifted through our bags: stethoscopes, basic over-the-counter medications, simple things that we were told we were not allowed to bring, life-saving supplies that could have been brought in suitcases were denied, and these are the challenges that we're facing as aid workers that are entering. Lastly, we know that the NGOs that are on the ground, as Payal mentioned, there are so many that are being denied the ability to operate. Most recently, as we all know, MSF being denied the ability to operate will be a massive hit. In talking to many of my WHO colleagues, they're very concerned about how the services are going to be provided, given that a lot of the antenatal care that pregnant women are receiving, they're receiving at MSF clinics and other NGO clinics that are spread across the Gaza Strip. So I'll pause there, but I just wanted to kind of give a little bit of context about what we're actually seeing. The numbers are incredibly important, but when it comes down to it, the patients that we're seeing, the faces that we're seeing on the ground, are confirming everything we're seeing from the data itself. And I think the last just overall message I want to say is that, truly the most important people that can be present on these panels are our Palestinian colleagues, and out of fear of targeting, they don't feel comfortable to come and sit and have these conversations and speak about what they're witnessing and experiencing on a day-to-day basis. And that in and of itself is a crime. And so I just want to pause there and just say thank you for letting me be here today to help uplift some of the stories from the ground for my colleagues who truly are grateful that these conversations continue to happen, and they continue to need to happen. But I think probably the biggest thing that we'd all like to see is the actual action and accountability as we're reporting these things and have been since October 2023.
Um, Thanks a lot, Dr. Ahmed, for your insights and your updates uh, from the ground. I'm Sam Zarifi. I'm the executive director of PHR. I was a few minutes late to the start of this, actually, because I was at the UN for a meeting of the Palestine Committee, and what was particularly interesting there was an update from the UN agency uh, UNRWA, which is under severe pressure. UNRWA is effectively, especially for Gaza, the public service, the public sector in Gaza. It is the organizer of the work of NGOs, but it's essentially what carries out all of the basic public sector services. And as you may know, it has been facing significant pressure. Of course, the entire UN system is under pressure, but UNRWA has seen severe cuts in funding. It has now been banned effectively by the Israeli government. Its offices were just taken over and raided by Israeli security forces. And as a result, what we're seeing is essentially the inability of UNRWA to carry out its work. That's particularly important because we are now in a phase under a UN Security Council resolution where we're looking at a ceasefire and rebuilding. We've seen some indications, including to some extent an small opening of the Rafah crossing, but all of the indications are that the rebuilding and humanitarian resupplying is not happening at the pace that is really required. So one of the functions of the work that we've done together with the University of Chicago Law School and with our colleagues at PHR Israel is to raise alarms and to push the international community to provide urgent assistance that is needed. The conditions for women, for pregnant women, for new mothers, for newborns remain dire. Again, this is a group that is specifically protected under the laws of war and arguably, I think unarguably, something that all humans have an interest in supporting. And so there's a real need for pressure across the board to allow the rebuilding of some of the infrastructure, including through clinics, taking in of medical supplies. Again, we hear consistently about the problems caused by the opaque restrictions on so-called dual-use materials. But I think what we really are looking at right now are a need for antibiotics, basic medical supplies, specialized baby formula. These are all things that are within immediate reach of the Gaza Strip. They can be taken in very, very quickly. And so the restrictions on UNRWA, the restrictions that have now been placed on some of the humanitarian organizations like MSF actually seem entirely, frankly, irrational at this point. There really can be no justification for it. As Dr. Ahmed pointed out, justifications that were preferred related to the conduct of the conflict were, I think, in our view and in the view of many humanitarian agencies, not appropriate. But they don't really, certainly they don't exist anymore. And it's an immediate matter. It's crucial to move forward. The question is, how can the international community, and it says the SHR, but how can we push for an end to the violence? Among the things, in addition to the resumption of humanitarian assistance and the rebuilding of some of the infrastructure that's been destroyed, I think there are some immediate other things that we need to see. The reopening of humanitarian corridors, again, as our colleagues have documented. It's essential to reopen corridors to East Jerusalem and to the West Bank where the better healthcare is available. Rafah crossing is simply not operating at the volumes that is necessary right now to provide immediate assistance. And so, looking ahead, this is the reason for this webinar to some extent, and to our advocacy and engagement with the UN system, with the Israeli government, with whom we've communicated. And they have not really offered any kind of clear justifications for the ongoing restrictions at this point. So there is absolutely an important prospective element to the documentation efforts that we and our partners at PHRI and at the University of Chicago have undertaken. But I also want to point out that there is absolutely a need for accountability. The damage that to the healthcare system and the harms caused by the restrictions on food and military and medical supplies, were completely foreseeable. And in fact, they were foreseen. There were warnings issued about it multiple times. The International Court of Justice issued significant orders asking for some of these restrictions to be removed. So the question of accountability is crucial here, because we know historically around the world that without accountability, impunity will set in, and the violations of international norms that we've seen in terms of attacks on healthcare facilities, in terms of restrictions on food and medical supplies, and damage therefore to, especially again, to women and to children, demand accountability. And in this regard, again, it's crucial that international observers be allowed to go into Gaza, especially now that the Rafah crossing is open. And it's crucial for accountability processes to proceed. And here I really want to be clear. In terms of attacks on healthcare and the impact of the restrictions on medical supplies and food, in our engagement with the Israeli government, they, on one level, they said that there were no restrictions, but we have asked them to clarify the dual use policy, and we've asked them to clarify what's going in. But they've also said that they've laid a lot of the blame at the doorsteps of Hamas and other militant groups, including the reasons for targeting of hospitals, for corruption, or for stealing of aid. If that is true, we're not necessarily in a position to determine that. There has to be an investigation for that. I do want to make it clear that in order for us to find out that information, we asked every physician whom we were interviewing whether they had seen, for instance, evidence of militarization of hospitals. Now, it's entirely possible that physicians who are extremely busy, Dr. Ahmed, I'm sure you can speak to this, may not have seen possible militarization, but it is important that we didn't receive any separate evidence or information, documentation regarding militarization of hospitals. And to the extent that Israeli authorities have detained, arrested several healthcare workers, including on allegations of cooperation with Hamas and of militarization, it's important that those cases move forward and that there actually be some due process. And we haven't seen that either. And that adds to the sense of lack of accountability. If there has been militarization, then that's a war crime and that needs to be addressed. But if there hasn't been, what we've seen is really a significant erosion of the norm protecting healthcare and protecting the health of civilians during warfare. And that's significant for PHR's work, obviously not just in Gaza, but we have been following precisely this line of seeking accountability in other places, in Syria, in Ethiopia, in Ukraine. And so this is a matter of global importance. And so this report does also have a retrospective element, and we don't want to forget the importance of accountability efforts while we're pushing immediately for an improvement in the situation facing civilians in Gaza. I have a question, Dr. Nahreen, from the audience, if I can share that with you. Given the starvation of mothers and children there are likely to be considerable growth and development problems for the young children. How significant is this likely to be, and how much of a problem will it be for these children from now? Are these problems likely to be permanent for the children? This is something that we've addressed, I think, in both of our reports. But Dr. Ahmed, maybe you're in a good position to maybe talk about what you've seen.
Yeah, this is such an important question because it targets the discussion, it kind of brings up the discussion of the long term and how this is truly a targeted attack on a population over time. The thing about malnutrition, especially in children, the vulnerable window starts when mom is pregnant. And so with mothers being malnourished and then thereafter, mothers being unable to breastfeed or the poor access to formula for children, you're seeing that there's considerable growth delays, cognitive delays. With cognitive delays, then come the inability to, kind of proceed through school if school is actually available, which means that, potential for employment down the road. These are kind of the long-term social determinants and consequences that we see. From a physical perspective, of course, the biggest thing is that malnutrition leads to poorer health overall. And we there's historical precedent for this, where the many man-made famines that have happened in history, and some of those long-term effects include things like chronic heart disease, high blood pressure, diabetes, things that kind of develop, and you see this in the South Asian population due to the Bengal famine, just to give an example of sort of long-term known consequences. So this is kind of in the long term what we worry about, and in the short term, of course, there's the depressed immune system is probably the biggest short to medium term effect that we worry about. And why is this a problem? It's because, especially right now, you're dealing with respiratory infections, diarrheal infections, crowded conditions that can lead to communicable disease. This is very worrisome for children who are immunosuppressed due to the fact that they're severely malnourished. And we are seeing this. The number of deaths from diarrheal illness, from respiratory illness has increased, or the morbidity has also increased, meaning that the long-term physical consequences and disabilities that are associated. The other big one is that many of the children, unfortunately, are survivors of traumatic injury, and poor wound healing is one of the things that we have seen over and over again. And I know that we haven't necessarily focused on this as much, but ceasefire violations are happening on a fairly regular basis. And when I was there for 3 weeks from end of November to December, they were happening on a daily basis. We were seeing children come in with traumatic injury from ceasefire violations, missile strikes, quadcopter injuries during that time, during the ceasefire, and extremely poor wound healing leading to infection and death from and concern for death over time from poor wound healing and infections that we couldn't treat properly. So those are kind of the short-term, medium to long-term consequences that we worry about with severe malnutrition.
Thanks, Dr. Ahmed. Yeah, I mean, potentially significant impact that again requires immediate attention. Let me jump ahead to a question that's been posed twice now, and I guess this is directed to you also, Lama. Is how can the SRHR community show up more to support the efforts to end the violence in terms of what you're doing, what you're seeing inside Israel, but also I think as a global issue?
I think mainly to pressure, like to uphold the ethical codes. We do see a lot of pressure on the Israeli Medical Association happening internationally. I think much more pressure need to be applied to alleviate the harms done to pregnant and breastfeeding mothers. And that would be for sure to uphold the ethical codes in this context.
Thanks, Lama. I think again what I saw today at the UN is just being clear that the ceasefire has not ended the problems. I think there are so many issues right now, so many fires burning around the world, and it's important. This is an instance where it is possible to provide immediate assistance right over the border. So the logistics are there.
Maybe
Payal,
if I can jump in, yeah, Sam. I
yeah.
think just to say, I think SRHR organizations, in part, there have been many that have been a bit hesitant to engage, particularly during the active conflict. But now that we're in this ceasefire phase, I really think it's another opportunity for organizations to reconsider and to look at their positions. And at this point, we are talking about a context, right, where we're in this ceasefire phase and we're looking actually at the needs of populations. We're talking about rebuilding health systems. This is really squarely in the work of sexual and reproductive health and rights organizations. We're also seeing attacks on international humanitarian agencies being able to come in to provide care. I think it is critical that we all speak up. The danger of the erosion of these norms around the right to healthcare, around obligations of occupying forces, they're serious. Without kind of taking us too far away from the conflict that we've been discussing, I think we're also seeing the knock-on impact in other contexts where, we're continuing to see that attacks on healthcare are being enabled, and then denial of essential healthcare is also being permitted and tolerated. So I think it is really critical that this community stands up more. I think to the extent that while the conflict was ongoing, there were political considerations. I think it's also critical there's a reassessment of those considerations and a real acknowledgement that these are real individuals. That Dr. Ahmed really clearly showed us, right? These are real people that you're seeing on the ground day over day facing completely treatable conditions or preventable conditions that we as a global community are not mobilizing enough to respond to. And it's really critical we use our voice to speak up in this context.
Thanks, Payal. And I guess let's try to wrap up. There's a question directed at you, and in terms of the tools in international law, international criminal law to achieve accountability for these harms. And I hand it over to you, Payal, but I do want to point out that under international law, the primary obligation still rests on the state of Israel as the state that is the occupying power. It's a state that we know has the capacity to provide accountability if there is political will. And so before we get to international mechanisms, there's no there has to be clear that the obligation rests on the state of Israel to show that it can provide accountability for what has happened. Payal?
That's my response as well. And I actually think this is not a situation where we're seeing a vacuum in the international law itself. There are very strong and clear prohibitions on what we're seeing or documenting. But there is a political will challenge, and I think that is something that needs to be addressed. There are also barriers that are coming from the inability to access Gaza for investigators to be able to come in, as Sam shared, and I think that is a critical gap and something that needs to be addressed. And then, of course, there are sanctions on some of the international accountability bodies or body that is looking at specifically violations of international criminal law, which is what this question is referring to. And I think that's obviously another major consideration and concern in terms of accountability.
Thank you, Payal. Thank you, Lama. Thank you, Nahreen. Lindsay, if you're there. Thank you to all the colleagues. Thank you to everyone who joined us today. This is an issue that obviously has global impact and interest, but our first focus should remain on the civilians who've been harmed through the course of this conflict, the significant erosion of international law that we've seen from the beginning days of this phase of this conflict, attacks on civilians, the taking of hostages, but the relentless attacks on civilian facilities and on healthcare facilities. These are part of a pattern of breakdown of international norms that we at PHR have been documenting and that we are seeing again in conflicts around the world. But we know that the only way forward is to demand accountability and to try to protect the civilians, and in particular right now. We appreciate your support for the work that we do. We appreciate your support and your engagement on this issue. And as always, please feel free to contact us if you have more questions and comments. So I think on behalf of our colleagues at Physicians for Human Rights Israel, at the University of Chicago Law School Global Human Rights Clinic, and at Physicians for Human Rights, thank you and goodbye.